From the JAMA Network, this is JAMA Pediatrics Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Pediatrics.
Hello again, podcast listeners. This is Dimitri Christakis, Editor-in-Chief of JAMA Pediatrics. I'm pleased to say we are now once again the premier pediatric journal in the world with the highest impact factor of any pediatric dedicated journal.
Woohoo!
Coming to you again, as always, with Associate Editor Dr. Alison Galbraith from BMC. Hi, Ali. How are you?
Hi, I'm good.
And as you loyal listeners know, we've rebooted our format now. I shouldn't even say it's a new format because we've been doing it for quite a while, but we use a recently published paper in JAMA Pediatrics as a segue to discuss an important topic in pediatric health. And we enlist an expert on the relevant condition or problem. And I am very pleased to say that this month we have the considerable honor, privilege of having Dr. Stephen Daniels, who is Professor and Chair of the Department of Pediatrics at the University of Colorado School of Medicine, and the Pediatrician-in-Chief and L. Joseph Butterfield Chair in Pediatrics at Children's Hospital in Colorado. I've known Steve for a long time. He's a truly international expert in cardiovascular disease in children and adults. Stephen, thanks for joining us.
Thanks for inviting me. Looking forward to this conversation.
Great to have you. Ali, why don't you start by telling us what paper prompted us to look Steve up today?
So this paper is called Long-Term Cardiovascular Outcomes in Children and Adolescents with Hypertension. It's by Robinson et al., mostly from Canada and a few other places. They wanted to study whether children and adolescents with hypertension were at increased risk for long-term major adverse cardiac events. We know that hypertension tracks from childhood into adulthood and is associated with some subclinical cardiovascular disease outcomes, but they wanted to see the next step to see if it's associated with actual major cardiac events. So they did a retrospective matched cohort study of all children in Ontario, Canada, who were ages 3 to 18 between 1996 and 2021. And they were able to include all of them because the Ontario Health Insurance Plan covers everyone in that area. And then they also excluded kids who had prior dialysis or kidney transplant. So they identified the children with incident hypertension using ICD-9 and 10 claims, and they propensity score matched them with 5 controls who didn't have hypertension. And then they followed them and measured their outcomes in the claims as time to major adverse cardiovascular event. So that was a composite of cardiovascular death, stroke, hospitalization for myocardial infarction or unstable angina, or a coronary intervention. So what they found among about 25,000 children with hypertension that were matched to about 128,000 controls, the incidence of a major adverse cardiac event was 4.6 per 1,000 person years if you had hypertension and 2.2 per 1,000 person years if you did not. So the hazard ratio was 2.1. It was a significant increase. And this is over a median follow-up of about 14 years. They also found that the kids who had hypertension were at increased risk for each of the separate components of the composite major adverse cardiovascular experiences measure, except for cardiovascular death. And those who were younger than 13 at the incident diagnosis and those with chronic kidney disease were at higher risk. So they concluded that there's a increased risk of major adverse cardiac events for children with hypertension compared to those without, and that they are concluding that we need more blood pressure screening and awareness about pediatric hypertension to be able to optimize hypertension care and prevent adult cardiovascular disease.
Curious on your take on that, Steve, your sort of first reaction.
I think this is a really interesting study and actually a pretty important one because I do think it fills a gap in our knowledge. We've known for quite some time that in adults, the relationship between hypertension and these adverse events is quite strong. And we've also known that improving blood pressure with treatment can reduce risk. It's been a longstanding question about whether that same thing is true for hypertension in childhood and adolescence. There have been a number of studies that have shown relationships between hypertension in childhood and adolescence and what might be called intermediate markers or subclinical markers. So there's been a lot of circumstantial evidence that, in fact, hypertension is not good for cardiovascular system over time. But the association between hypertension and actual events is really important. And they're really one of the first to demonstrate that. I think it's very helpful in increasing our evidence base around the importance of hypertension.
Do you think, Steve, that it's enough to change some of the guidelines? Like, I know that there's conflicting guidelines, right? Like the AAP and NHLBI recommend that we should screen regularly, but USPSTF doesn't say we should do that. Do you think this changes things?
This is not a new conversation, which I think is important to note. I think it's good to put the U.S. Preventive Services Task Force recommendations in context to remind everybody that their approach requires a very high level of evidence to create a letter grade around whether it's recommended or not. And their conclusion was an I statement, which is insufficient evidence either for or against screening. I do think that studies like this help fill some of those evidence gaps, because one of the things that they're looking for is this kind of long-term relationship, a life course type of relationship. And what's been very hard is thinking about the kinds of studies that can actually provide that evidence. And I've always worried that it's very difficult to fill that gap. This study obviously relied on existing databases and combined databases and took advantage of a healthcare system that exists in Canada, which I think is quite helpful. But when you think about the usual funding cycle for studies and other things, usually they're 4 or 5 year cycles with requiring renewal. And when you think about a situation like this, where you're potentially talking about multiple decades between the exposure and the outcome, that's a difficult thing to study. And of course, what this doesn't show is whether treatment of hypertension in young individuals would actually improve risk. And that's an even harder thing to be able to demonstrate.
Well, that was my next question, right? Because I think we tend to, minimize incidental findings of hypertension, and even when we did screen. And then, at least I think, maybe I'm wrong, the single biggest cause in pediatrics is obesity, right? And so we always sort of feel like, well, we should try to treat the obesity first, but we never do that very well.
Obviously, with new pharmacologic agents that may be helpful in treatment of obesity, even in younger individuals, some of that may change. But I do think there hasn't been the kind of attention to hypertension that it probably requires. And, I've thought for a long time that the fact that hypertension is associated with things like increased left ventricular mass, left ventricular hypertrophy, other carotid intimal medial thickness, other types of intermediate outcomes, which we know in adults are also associated with adverse events, suggests to me that the hypertension is already having a meaningful effect on the cardiovascular system, which seems to indicate risk for these kinds of events that they were able to demonstrate in this study. And there is emerging evidence that treatment of hypertension can ameliorate some of those intermediate types of outcomes, although we need more evidence along those lines.
In children, Steve, or in adults?
There are a few studies that are showing that treatment can have a favorable impact. But again, they're small studies. Most of the clinical trials of antihypertensives have just focused on reducing blood pressure and demonstrating that the pharmacologic agent reduces blood pressure, not as much on these kinds of outcomes. So we definitely need more studies along those lines.
Do we, though? You've put together a lot of pieces here. And what is first-line treatment for hypertension in children these days? We always recommend lifestyle modification, but it doesn't work. GLP-1s might change that. Let's put that aside, as you said, because there's a lot of unknowns there. But what is pharmacologic first-line treatment?
So it's true. Treating obesity in pediatric patients is really complex, but you can also have lifestyle approaches to improving the blood pressure that don't necessarily have to focus on reducing obesity. So a DASH type diet.
So Steve, on behalf of many of our listeners who probably don't know what a DASH diet is, can you tell us what a DASH diet is?
DASH stands for Dietary Approaches to Stop Hypertension, and it's a diet that is built around increasing fruits and vegetables, lowering saturated fat in the diet. It has some components that are quite similar to the Mediterranean diet, and it in itself doesn't necessarily lower sodium, but when you add lowering sodium to the DASH diet, you essentially have a diet that is an overall healthy diet, but it lowers sodium and actually tends to increase potassium, both of which can be helpful in treatment of hypertension. And in clinical trials in adults and now in children, it's been shown to be effective at lowering blood pressure. Increasing physical activity can have a beneficial effect on blood pressure. Lowering sodium in general can have a positive impact, at least on sodium-sensitive individuals. So I do think it is important to think lifestyle first, but it's also important to recognize that there are situations where lifestyle may have an impact, but not enough to lower blood pressure to where you really would want it to be. And it is important to potentially think about pharmacologic agents. And that's especially true for secondary forms of hypertension, where the blood pressure is the highest. Circling back to this study, they included not just primary hypertension, but secondary hypertension. So hypertension related to renal disease, other factors, which I think may be one reason why they were able to find this relationship in a population that was still pretty young when they looked at their outcomes.
Yeah, Steve, that's one of my questions for you is, if they're just picking up the kids who got a diagnosis and a billing claim for hypertension, so presumably more severe or picked up in relation with renal disease or something like that. And if we were just going to do screening, we'd probably pick up a lot of sort of isolated hypertension. Do you think picking up those other more isolated cases would be also beneficial? You think those kids are going to go on and have these outcomes? And also when we're talking about treatment, and the positive impact of treatment, is that on the kids with these sort of isolated hypertension diagnoses, or is that more secondary?
I think it's fair to say that the way they identified children with hypertension identified the more severe end of the spectrum. And they point out that their algorithm has very high specificity, but pretty low sensitivity. So almost certainly there are patients with hypertension that didn't get included in this study because they wouldn't be picked up by the algorithms they used with the electronic health records, et cetera. The other thing they found was that hypertension that began earlier at a younger age was also more highly associated with these outcomes. And we know that hypertension at younger ages in childhood may well be secondary forms of hypertension. So I do think that this all should be taken into account when we think about what this study means. But I will say that when you look at the range of blood pressure and you look at the relationship of blood pressure to some of these intermediate outcomes, left ventricular hypertrophy or carotid intimal medial thickness, actually blood pressures even below what we would consider in the hypertensive range have been shown to be associated with those early changes in the cardiovascular system. So to me, that reinforces that while this may not be the whole picture presented in this study, I think we do need to pay attention to those children and adolescents with even slightly lower blood pressures that may be having an impact.
So let me bring this back to like the practical, because some of our listeners are for sure now either on their way to or in their practices and seeing children for well child visits or detecting high blood pressure. What should they do from a very practical standpoint? It's a single isolated elevated blood pressure at a well child visit. What's the next step?
The recent American Academy of Pediatrics guidelines are really good for giving pediatricians and family physicians an outline of how to deal with this. One important part of this that we didn't talk about and actually isn't reflected in this study is it's not easy to measure blood pressure in children. From a primary care perspective, really having attention to detail in terms of measuring blood pressure can be really important. And that includes picking the right cuff size and all the other things that go into that. The other thing that's important about pediatric hypertension that's somewhat different than adult hypertension is that we require persistence of elevation of blood pressure to qualify as hypertension. So one elevated blood pressure really isn't enough. What you want to see is blood pressure that's in that hypertensive range over several visits over time to be sure that you, in fact, are dealing with true elevation. Now, the other thing that's true, and again, doesn't completely come through in this study, is that so-called white coat hypertension is actually pretty common in children. So this is where the role of 24-hour ambulatory blood pressure monitoring may turn out to be very useful, because if you're in a situation where you have a child with hypertension, you've tried lifestyle interventions, you're not really getting where you want to go, I actually think a 24-hour ambulatory monitor test can be really helpful, because if it shows persistence of hypertension outside of the clinic, then you can feel more comfortable that this is really something that you need to deal with. And if you add on to that an echocardiogram to look at left ventricular mass, and you find left ventricular hypertrophy, you then get the message that this elevated blood pressure is already having an adverse impact on the cardiovascular system. So that's the kind of child I think that needs more aggressive intervention. And I think this study would suggest that that's likely to be a child on the way towards some of these major adverse cardiovascular events.
Would you forgo pharmacological treatment before you got an echo? Would you want to see end organ changes before you started medication or not?
So if we're excluding patients with stage 2 hypertension, the very highest range of blood pressure, which I think needs more immediate attention, needs evaluation for whether there's a secondary cause of hypertension or not, I think you're in the realm of shared decision-making with families. I actually think that an echocardiogram and a 24-hour ambulatory monitor are very helpful in having that conversation about, should we take that next step to more aggressive intervention and a pharmacologic intervention. So in our hypertension clinic, that would be our approach. We would do those things before starting a pharmacologic agent.
And are those meds pretty well tolerated for kids and adolescents?
I think antihypertensive medications are very safe and very effective. Unfortunately, pediatricians don't have the same kind of experience using them that an adult primary care physician would have. So for better or for worse, hypertension often ends up being more of a referral scenario in pediatrics. And maybe it should actually be more in the realm of pediatric primary care. But I think at the moment, a lot of pediatricians feel uncomfortable about this.
It sort of reminds me of where we were with SSRIs like 8 or 10 years ago, where most pediatricians were totally uncomfortable prescribing them, and the waits to get into specialty clinics got so long, and I think many more are comfortable prescribing SSRIs now.
That's exactly right. And I think you could make the same case around treatment of dyslipidemia. So there's some other categories of things that really probably should be in the realm of primary care.
Well, I want to thank you so much, Steve, for taking time out of your very busy day. I found this incredibly enlightening, and hopefully it was very helpful to our patients, providers, and families out there. Thanks again for taking time with us, and thanks for all that you've done to advance our understanding of cardiovascular disease in children and adults.
Well, thanks for inviting me. And I hope people will take a look at this paper, because I think it's an important paper and one that's well worth reading.
This episode was produced by Shelley Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or wherever you get your podcasts. Thanks for listening.